It's just kind of the core stuff which you need to kind of get on with the job day to day when you start, or if you've started. Feel free to ask any questions either during on the Facebook live feed. We'll have someone monitoring that and feeding it back to me, and also if you want via email as well. So the general format of the session, of all our sessions, will be there'll be a case. We'll briefly describe the anatomy and the pathology associated, in this case with gallstones. We'll talk about the different disease presentations and how they come about, the etiology, and talk about core principles with investigation and management. And there'll be some questions at the end. So a bit about myself. My name's Marc. I'm an academic FY2 doctor based in London with a surgical interest and a teaching interest as well. So the learning points for this talk are going to be, there'll be four main ones. It will be understanding the kind of science behind gallstones, just enough to appreciate how the diseases present, as opposed to kind of going into nitty-gritty preclinical sorts of things. The second will be appreciating how gallstones can present, the spectrum of presentations that they can have, understanding key concepts for investigation and management, and then applying these skills to a case, and also going through some sort of less common presentations of gallstone disease at the end. I'll try to take up not the full hour, because I'm sure you'll have busy things to do, but we'll try and be as brief as we can. So we'll start with the case. So you're the surgical FY1 on take when a 45-year-old female presents with a background of type 2 diabetes, hypertension, and obesity. She complains that she's had a number of intermittent right upper quadrant pain episodes, usually after meals, and I'm sure you're already thinking about what this could be. She's been having it for a while, but over the past week, it's been getting worse, and particularly overnight since her dinner yesterday. She now feels very unwell, kind of shivery, shaky, and her partner has noticed that her eyes have gone a bit yellow. So have a little think for 30 seconds to a minute about the different things this could be. I know you're probably jumping to one thing already, as we all would do when we start clerking, if it's fairly simple, but try and cast your net a bit wider and think about other questions that you might want to ask before we carry on and talk about what else is going to come up. So you can use the chat function or write it down on a piece of paper, or just have a think for the next few seconds. Brilliant. So I'm sure there's some stuff coming up. So some of the questions that I would want to ask is it's a fairly simple presentation, but you really want to get an idea of the timeline, because it does make quite a big difference if, for example, the patient has been having pain on and off for the last few months and suddenly it's got worse, or whether this was it's all the symptoms are brand new and it's just been going on over the last few days, because it makes a difference in terms of what it could be. The pain, obviously do a Socrates history, and each letter of that Socrates will really, really help in terms of your differentials. So the site, I know with a gallstone disease talk, but the site is important. If it were more central, you might be thinking dyspepsia, pancreatitis. Right upper quadrant, you're thinking about the biliary system. The onset, when did it originally start? The character. So what does it feel like? In this case, it would be, wrenching or stabbing, which will then come and go. There might be a dull ache in the background. The radiation is important. So whether it radiates to the shoulder tip, for example, if you're affecting the phrenic nerve, or round through to the back is very common as well. Associated features, so your nausea, your vomiting, and a brief systems review. The timing, so in this case it comes and goes, which is different to something like pancreatitis might be there constantly, and then exacerbating features and severity as well. So each bit of that will really help you narrow down your differentials. So the associated symptoms, the jaundice, you need to ask a little bit more about, try and characterize when it started, how bad it is, and the associated things with jaundice, because of I know you had a talk last week about the biliary system and enterohepatic circulation. So if you're familiar with the fact that that will cause you to have pale stools and dark urine. The jaundice can affect the whites of your eyes, which we call icterus, and it can affect the skin, which is jaundice. The systemic symptoms is important in this case. So that's the fever, the shivering, the kind of being unwell, the malaise, which we'll get to the diagnosis later, but that's important. And whether they've had any previous episodes like this, what they've been like, and whether they've had any abdominal surgery. Of course, if they've had their gallbladder out in the last, whenever, then that makes a big difference to what you think it might be. So carrying on, so she's had these episodes for the last year, but it's in the kind of postprandial, so after meals, particularly when they're fatty, and it's always in the right upper quadrant, so just underneath her rib, kind of the costal margin in the mid axillary line. The urine has only recently in the past few days become dark. The stools have become a bit pale, and she's a bit itchy. She's not seen anyone about it over the last year when you ask, because she just thought it was indigestion because she only gets it after meals. But now that she's become, sweaty, shivery, and yellow, she's thought that she would go to get help. Okay, so keep having a think about what the different things it could be. And we're going to do a little bit of a sidestep now from the case and talk a bit about anatomy. So very generally, we'll start off. You've got the alimentary canal, you've got the stomach, and in the second part, the medial aspect of the second part of the duodenum, you have the ampulla of Vater, which is guarded by the sphincter of Oddi. So that's, I think my mouse works. So this area right here, which is the opening of the main duct, which is a combination of the pancreatic duct and the common bile duct. The common bile duct, if we follow it up, splits into the cystic duct, which goes to the gallbladder, and goes up to the common hepatic duct, which then splits into the right and left. The cystic duct is a branch, and it's often a lot more curvy or corkscrew-like, which then is how the gallbladder is how the bile gets to the gallbladder in order to fill. And then when you eat through the cholecystokinin, which is the hormone which will cause it to contract, the bile will then flow out of it down the cystic duct and out into the alimentary canal. So that's the general anatomy. Important thing on the kind of cellular level in the liver, which might come up in exams or on ward rounds, if you're being quizzed, is that the hepatocytes are arranged into hexagons. At the center of the hexagon, there's the central vein, and on the outside is the portal vein, the hepatic artery, and the bile duct. Whilst the blood flows, from the intestines through the portal vein, it will flow towards the central vein, i.e. it's getting filtered and it's going that way. The bile will go in the opposite direction and then will collect in the bile duct and go out the liver that way. So a bit more specifically, you've got the stomach. Below that, you have the greater omentum, which hangs down like a drape over the intestines. You have the lesser omentum, which connects the lesser curvature of the stomach to the undersurface of the liver. And behind that, if you were to poke a hole through it, you go into the lesser sac. There's one natural way you can get into the lesser sac, which is through the foramen of Winslow. So imagine you could put your finger through that hole and it would then disappear behind the lesser omentum. So the gallbladder is up here. It's a fibromuscular sac with a capacity of about 50 mils. It's lined by columnar epithelium. Some important relations. So on top, anterior, you have the liver. Posterior, it's covered by peritoneum. You've got the transverse colon and the first part of the duodenum posterior as well. And on the side, you have on the right side, right lateral, you have the right lobe of the liver. And medially, you have the quadrate lobe of the liver. It's supplied by the cystic artery, which is in most people a branch of the right hepatic artery, and it directly goes into the liver in terms of venous drainage. Importantly, there's something called the Calors Triangle, which will be mentioned by most people on, most consultants if they're in theatre, and will come up in exams, which is the triangle bounded by three things. So medially, you have the common hepatic duct. Inferiorly, you have the cystic duct, and superiorly, you have the inferior edge of the liver. And the reason it's important in theatre is because that's the area that surgeons will need to appreciate And when we say appreciate, we mean we'll have to find all three of those features in order to be sure that the cystic artery is running in between it, because the contents of the hepatobiliary triangle, Calors Triangle, is almost always the cystic artery, which when you're taking out the gallbladder needs to be clipped and secured. This is just another view of the celiac axis. Yeah, last week you went through the mechanism for bilirubin and how that creates jaundice. So just a very, very brief overview for those who might not have been here last week. You have the breakdown products of red blood cells, which goes into heme, broken down into bilirubin, which is then conjugated in the liver from unconjugated bilirubin, which is less soluble, to conjugated bilirubin, which is then excreted. And it forms the yellow of your urine and the brown of your stool. So back to the case. 45-year-old female presented with right upper quadrant pain. She's having jaundice and malaise. So a few more things for you when you assess her. So observations: her heart rate is 110 and her blood pressure is 89/40. So already that's not a great sign. You've got a heart rate which is above the systolic of the blood pressure. Which is, the reason that the heart rate is high is because your body has compensated to maintain cardiac output. The blood pressure is low, so you want to maintain the perfusion pressure by increasing the heart rate. The temperature, very febrile, and slightly tachypneic, very tachypneic as well, and saturating well on air. So on the examination, you've got scleral, icterus present, no jaundice in the skin. But so you just have it in the eyes. So you'd expect the bilirubin to be in the region of 30s, 40s. You wouldn't be kind of sky high in the 80s, 90s, because then you would see some jaundice. And importantly, there are no stigmata of chronic liver disease. When you feel the tummy, the abdomen is soft, so there's no guarding. Well, there's some voluntary guarding, which is a bit of a misnomer, but it's maybe distractible guarding is a better term, which means that when you're pressing on it, it will hurt and they'll tense, but you might, start chatting to them about something completely unrelated and it might soften up just a tiny bit. So she's Murphy's sign positive. So that's an important sign which everyone will be familiar with, which is on palpation of the right upper quadrant during a deep breath in, which forces the diaphragm lower and therefore presses the gallbladder up against the abdominal wall, which will then hit your hand. That causes pain, which is a sign for, cholecystitis and cholangitis. So it's a sign of inflammation of the gallbladder, but we'll get into the differences in a short while. Boas sign positive. So that is slightly less common, and it is hyperesthesia. So pain when there shouldn't be pain on light touch. So if you just stroke the inferior area of the scapula on the right-hand side. So if you stroke the back on the scapula, it will hurt them, which is obviously not a normal thing, and it's to do with the referred pain and the dermatomes of the gallbladder. Korsavage sign negative, which is painless, which was covered last week, and that's when you have painless mass in the right upper quadrant, which usually signifies pancreatic cancer. But in this case, it's painful, so that's why it's negative. So the diagnosis, so I'm sure everyone has appreciated by now that it is cholangitis. And we're going to go through the differences between all of the different gallstone presentations. And there's a spectrum, and it goes from asymptomatic gallstones through to cholangitis across biliary colic and cholecystitis. A few definitions. You have cholelithiasis, which is gallstones in the gallbladder. So that's just the presence of gallstones in the gallbladder. Choledocholithiasis, with that extra doca bit in the middle, means that there's gallstones in the CBD, in the common bile duct, which we talked about slightly earlier. Cholecystitis, itis being the suffix for inflammation, is inflammation of the gallbladder. Cholangitis, again, the suffix for inflammation, but of the prefix cholange, which is the bile ducts. You have inflammation of the bile ducts. Cholestasis is when you have failure of the normal amounts of bile to reach the small intestine. So you have stasis, i.e. stagnant bile in the CBD, which is a risk factor and will cause eventually infection. There are some other ones, some more weird and wonderful presentations, which we will cover, but slightly quicker, which we'll go through a bit later. So gallstones, the definition, presence of solid stones within the gallbladder. There's a photo on the right there for you. 25% of women and 10% of men will have these across their lifetime, but only less than 2% per year will actually develop symptoms. So that means that a minority, not a majority, of people with gallstones will ever have anything, will ever have any symptoms. And that's important to appreciate. So there'll be lots of times where you might have scanned their abdomen for a completely unrelated reason, and you'll find gallstones in their gallbladder, but you won't be doing anything about it. So cholelithiasis, continued pathophysiology. So we have different types of gallstones. They can be made up of different things. They can be made up of cholesterol. They're usually a bit larger and fewer, or they can be made up of pigment, which is usually more heme in it. So they'll be smaller, they're more regular, and they'll be darker. Mix is the most common, where it's a little bit of both, but predominantly cholesterol. They usually form in the gallbladder and then can travel through the cystic duct down the common bile duct, which is more common in the West. But in the Far East, you can actually get gallstones which develop de novo in the common bile duct itself. So why does it happen? When it comes to the cholesterol, you have an increased dietary cholesterol, and that will cause the bile salts which accumulate in the gallbladder to be supersaturated, which means that they can't form micelles, which is when it kind of acts like a soap and will and form a sort of spherical structure. It can't do that properly because it's too saturated with cholesterol already. And therefore it forms a precipitant, which over time will form into stones. You can also have excessive hemolysis, which will usually cause the pigmented type of gallstones to form. And they will be causing the pigmented type of gallstones. And that's because you get excessive heme breakdown. And even though the rest of it is normal, the system can't keep up, and therefore you get precipitation. So some risk factors. For cholesterol, you have the 5 Fs, which people may have heard about. So female, 40, i.e. slightly younger, fat, so being obese, overweight, fertile, because exposure to estrogen is a risk factor or is part of the pathogenesis, and fair, as in being light-skinned. Hematological conditions, which will be touched on with excessive hemolysis, so hereditary spherocytosis, G6PD, and sickle. Also, rapid weight loss, which surprised me the first time I learned that. But if you lose weight too quickly, all that cholesterol, all the fats which were in your kind of adipose tissue, suddenly go into your bloodstream and then suddenly have to get rid of, get excreted by the body if they're not burnt up. So you'll get a increased chance of them precipitating in the gallbladder. So pregnancy as well, because you get bile stasis and other types of infection in general. You get problems with enterohepatic circulation. So if you have Crohn's disease and you resect, the terminal bit of the ileum where a lot of the bile is reabsorbed as part of that enterohepatic circulation, then you get kind of a gallbladder which is having to deal with, because you're losing so much, it has to produce more to keep up, and therefore you get a higher chance of them precipitating and forming gallstones as well. So to talk about the spectrum of gallstone disease, asymptomatic gallstones, as we touched on, it happens to lots of people, you leave them alone. Biliary colic, that's when you have gallbladder spasming against the obstruction. So you have a stone either in the gallbladder itself or maybe in the cystic duct, and the gallbladder is trying to squeeze against that, and it can generate up to around 20 millimeters of mercury of pressure. So it's quite powerful, and that's where you get the colicky sensation. So a bit like renal stones, when you have something contracting against an obstruction, it causes waves of pain. So that presents as right upper quadrant, colicky, pain after fatty meals. And the reason that fatty meals is brings out this symptom is because that's when bile is needed most. So bile is used to help digest fatty foods. So when you eat a fatty meal, you get a higher release of cholecystokinin, and therefore a higher release of a increased contraction of the gallbladder to try and digest all that extra fat that you've eaten. And it self-resolves. So it's squeezing and then it being painful, and then it will resolve after that bout. So you don't have any jaundice or systemic symptoms. You might want to do some LFTs and an ultrasound to actually prove that there is gallstones. And most people, if it's just 1 or 2 episodes, they'll choose to leave it. But if it's happening very frequently, it will be cumbersome for the patient and it will be very painful. So they might want it out, i.e. a laparoscopic cholecystectomy. And also once, with recurrent bouts of biliary colic and lots of gallstones in the gallbladder in that context, you'll be at a higher chance of developing cholecystitis. And you always give them discharge advice, to reduce fatty meals, to lose weight and exercise and things like that. So the next one up, cholecystitis. So this is a step up because there's inflammation of the gallbladder. So you have everything you had with colic, but in this case, at some point, it's led to inflammation and sometimes infection of the gallbladder. And that means that you have fever as well as all the things you had for biliary colic, and you'll be tender in the right upper quadrant as opposed to just having pain there. And that's because when you press it, you're touching something which is inflamed, so that causes pain. So in this case, you give antibiotics, you give fluids, you treat everything, you treat all the symptoms, and you treat their pain with analgesia and things like that. But the gold standard, kind of the thing that needs to happen, is you need to take the gallbladder out. Over the last decade or so, there's been conversations in the literature about whether that should be done electively once the bout of cholecystitis has died off, or whether that should be done in the acute phase. Most people that I've seen and most things that are written about now advocate for what they call hot gallbladders, so taking out the gallbladder during the active phase of inflammation. But that should really only be done in the first 48 hours or so. If you wait longer than that, then all that inflamed tissue you'll start to develop adhesions. So little fibrous bands, which will make everything very matted down, which will mean that A, it's very hard to appreciate Calors Triangle, which we talked about earlier, and B, much more likely to accidentally, tear off a bit of the common bile duct or accidentally avulse parts of things because the anatomy isn't as clean. So in that case, if you're kind of presenting, in the 5 days to a week sort of thing, then you'd wait and do it electively afterwards. The reason you want to do an MRCP pre-operation is because the last thing you want to do is take out the gallbladder and then they come back later on with symptoms of cholangitis because actually there was a stone in the common bile duct which you hadn't realized. And so even though you've taken out the gallbladder, they've still got cholangitis. So that's not ideal. So most centers will advocate the use for an MRCP preoperatively. And if they do find a stone in the common bile duct, then they'll have to do an ERCP to fish it out. But we'll talk about these things in a minute. So the last spectrum, the last one on the spectrum is cholangitis. So this is when you have infection of the whole biliary tree. And it's usually, most commonly, E. coli, which makes sense because in the same way that, UTIs are most commonly E. coli because of, E. coli coming from the intestinal tract up through the urethra into the bladder. This is E. coli coming from the intestinal tract up the biliary tree and causing infection. And that usually happens when there's stasis. So there's stasis of there's stagnant bile, and therefore the E. coli can travel up and cause it to become infected. And this presents with fever, jaundice, and right upper quadrant pain. Importantly, there's jaundice because there's blockage of the biliary tree. And those three things are called Charcot's triad. When it's very severe, it's Reynolds pentad. When you get confusion and you have shock, so you have hypotension. Again, the primary investigations are the same, LFTs and ultrasound. And the initial management will importantly include sepsis 6. And that's the primary thing that needs to happen in order to save that person's life, because they're septic usually, and if they're not septic, they will become septic very soon. And so you need to manage that infection, and each hospital will have different guidelines, but you'll have to have some gram-negative cover in that. And you'll need to be speaking to HPB, hepatopancreatitis doctors urgently, because what they'll need to do is an ERCP. So an ERCP stands for endoscopic retrograde cholangiopancreatogram, So that's when you put something through the mouth, an endoscope, you go all the way to the ampulla ovata, and you put a device into the biliary tree. And you inject dye through that so that you can see a nice picture of the biliary tree. And you can also at the same time fish out the blockage. So it's both an investigation and a management. And then ultimately they will need a laparoscopic cholecystectomy as well once this whole thing has settled, because you don't want it happening again. So to talk a bit more generally about some of the investigations, whenever you're, going back to the case, what sort of things would we want to do? This person's presenting, they're febrile, you're the clerking doctor and you're the first one there. So either you're an ED or you're part of the medical or the general surgical team, and you're arriving, what sort of tests would you want to have done? So you can think about it as bedside, bloods, and imaging, which if you're doing OSCEs or exams in general, that's how you should frame your answer, because it makes you look more structured, which the examiners will like. And in real life, it's a fallback. So if you're panicking, you don't know what to do, just think, what can I do at the bedside? What bloods do I want and what image I want? And often things will just pop in. Having that structure in your mind will make you not miss things. So an ECG, you'll want that for everyone. And a lateral flow in these times with a fever, even though it seems unlikely, they may have that at the same time. And if they're going, especially for procedures where they might need intubating or at least have an LMA or something, then you'll need to make sure they're negative. You can do a urine dip, and in this case, you can look for conjugated versus unconjugated bilirubin, which will help you determine whether it's prehepatic, posthepatic jaundice, and a urinary pregnancy test as well, because especially if they're going for theatre. So blood tests, you want to do kind of all the normal ones, FBCs, UTNEs, LFTs would of course be very important. We won't go into the specifics of how they'll present, but you'll get a cholestatic picture. So you have a higher ALP than ALT, and that's because you have stasis of the bile. In cholangitis, of course. In the other types of ones, you would just have raised inflammatory markers. So the FBC and the CRP will show you that, but you'd have a normal bilirubin and LFTs. You'd want to get a baseline of the magnesium bone profile and amylase as well. You'd want to rule out things like pancreatitis, which may not seem completely necessary if you feel like you have the diagnosis. But remember, gallstones can travel further down and cause both cholangitis and pancreatitis. A group and save and clotting will be important, especially preoperatively. So the liver screen, ALP versus ALT, we've talked about. If you can do, in this case, you might not think about doing all these things, but just bear in mind there are lots of other tests. If someone asks you a full liver screen, if you're not quite sure what's going on, you can ask for all these different tests, which will all derange your LFTs to some extent. So the radiological investigations are important to appreciate with gallstone disease. We'll start with CT abdo-pelvis because it's not the best test for these sorts of things, but it's often the test that you'll get first. Either because at least the trust that I've been working at, people would come through at the front door, have an acute abdomen, and they'd almost automatically get a CT abdomen pelvis before surgical team even kind of got there. If you're overnight, there's 24 hours, there's a CT in every A&E department. So it's very easy to get ultrasound abdomen, usually working hours, usually 9 to 5. And you need a special ultrasonographer to do it. And they're usually only there during the day. And so it's just harder to achieve, even though they're a better test for things like cholecystitis. But there are still things that you can glean from CT abdo-pelvises. You can still see that the wall might be thickened, which will give you the diagnosis of cholecystitis. You can also measure how big the common bile duct is. So if there's a stone in it, all the common bile duct, which is proximal to it, i.e. close to the liver, will be dilated because of the blockage. Just like if you blocked the pipe behind it would swell. Sometimes, but rarely, you can actually see the stone itself. And of course, the advantage of it is that you can look for things like pancreatitis and other causes of acute abdomen if you're not so sure. But the first line investigation for gallstone disease would be ultrasound abdomen. With this, you get a very good look. So it's got a much higher sensitivity and specificity for finding gallstones, because usually they're made of cholesterol, and therefore the gallstones themselves don't show up on the CT abdominals, but they will. But they'll be echo dense, which you can see here, i.e. the sound waves don't go through them, so you can see them. You can see the shadow behind it here, and therefore they can be seen on ultrasound abdomen. With ultrasound abdomen, you can also look at the thickness of the gallbladder. So a thick wall would mean that it's angry and inflamed. That's cholecystitis as opposed to colic. And you can also look at things like the common bile duct size and things like that. Some disadvantages, as we said, time of day. Sometimes they're not, you're not able to get them right there and then. And also, if someone is particularly overweight, sometimes the views are quite bad because the probe has to shoot sound waves through a lot more tissue. So an MRCP and ERCP sound very similar, can sometimes give you similar information, but they are quite different. An MRCP, look at the first one, the first letter. So M for MRI. So that relies on water having different properties than the surrounding tissues. And so the whole biliary tree is full of bile, but that's a watery substance. So it shows up very, very nicely. And where there are gallstones, you can see that there's what they call filling defect. So there'll be an area where there's no water, no bile, and that way, and then you deduce that is a stone. And it's very sensitive to look for stones in the common bile duct. So the ultrasound abdomen, we mentioned, you can see them in the common bile duct, but they're not perfect at finding them. So they have. So you need an MRCP to be 100% sure that they're not in the common bile duct, which, as we mentioned before, is important because if you're taking out the gallbladder, you want to make sure that it's not in the common bile duct. So an MRCP, you might be able to see that there are gallstones, you might be able to see there's inflammation, but you can't at that stage do anything about it. An ERCP, however, is an investigation because you put a device, I'll show you a picture later, into the biliary tree, and you inject dye through it, but at the same time, you can fish out any obstruction that's there. So it's therapeutic, which is a big benefit, but it is invasive and it has quite a few complications, which we'll go into in a second. So some of the pillars of management. So we talked about how the investigations you have, bedside, bloods, and imaging. With management, again, you have conservative, medical, surgical. That should be your structure when you're writing up your clerking from the patient that we've just seen. And it should be your structure for when you talk about endoscopies and for when you revise. So conservative, treat the symptoms. If they have nausea and vomiting, you can give them antiemetics. If they have the itching, you can give them some topical or some antihistamines. Itching would be because jaundice in this case. Pain, treat the pain. Buscopan is particularly useful because it's an antispasmodic, which, as we said earlier, the cause of the pain for things like colic is because the gallbladder is spasming behind the obstruction. So that's why it's useful to give an antispasmodic. My consultant that I had in my hospital last year was a huge fan, almost made us prescribe PR Buscopan for everyone that came in with biliary colic because it was so effective in her opinion. I'm not sure about if there are any RCTs about that, but it did seem to work in conjunction with the others as well. And then conservative things, weight loss as well. We talked about that earlier. So the medical things, for cholecystitis and cholangitis, you're giving antibiotics, and you can look at local guidelines because each one has slightly different advice. And sepsis 6, we won't go through it, but there's the give 3 and the take 3. And if they're unwell, if they're very unwell, they're shocked and hypertensive, you need to get early intensive care input. Thermoprophylaxis, these people are usually overweight. They'll be sedentary for that period of time. They will often have other risk factors for clots, and they'll be acutely unwell. So considering prophylactic low molecular heparin is very important. And if they're overweight, over 100 kilos, then you need to give that twice a day instead of once a day. Be aware though, if they're going for surgery imminently, or if you think they're going for surgery imminently, then it might be wise to hold it until the consultant sees them in the morning, for example, or until a decision's been made to operate or not. Then you can, omit it for 1 or 2 doses. But the definitive medical management for some of these things, for if there's a blockage, would be an ERCP, and a PTC and drain we'll talk about in a short while. But that's if the ERCP fails. So the surgical management, you can have open surgery, the Kocher's incision, which is number 1 there, which you would have seen on patients, I'm sure, and laparoscopic, which has better operative outcomes and post-operative outcomes, which will often be accessed by 3 ports, one of them umbilical to get the camera in, and then 2 other ports. It's important to note that jaundice leads to bad outcomes, and that's well known in literature. It prevents effective healing. And we mentioned earlier about the hostile environment when adhesion's forming, and the importance of operating either early or letting it settle and operating afterwards. Some of the complications of gallbladder surgery is a conversion to open, which is considered a type of complication. A bile leak, so that's usually from the cystic stump. So when you have the cystic duct, that's clipped and the gallbladder is taken out, and sometimes that clip either isn't put on perfectly, or in the case of biliary radicals, there are some other tiny little channels for bile to get into the gallbladder, usually not by the cystic duct, but from the liver directly into the gallbladder, tiny ones. So when you take it out, some of those can leak. And that is usually can be treated by doing a stent and letting it heal naturally. So you're stenting it so that bile has an obvious tract, path of least resistance going straight out, so the leak will stop, and over time it will heal. The other one is a bile duct injury. So, for example, if you're doing it in a very hostile environment in day 5 or something, and you accidentally tear off the cystic duct from the common bile duct, you have a gaping hole in the common bile duct, then that would pose a big problem, and it wouldn't heal by itself. You can't stent it because the normal anatomy isn't there, and therefore you'd have to do biliary reconstruction, which the HPB surgeons will be that'll be one of the things that they'll be operating on commonly. For those who are interested, you get a Roux-en-Y reconstruction, and so you plumb part of the duodenum straight into the small intestine, so you get this spare limb, and then you plumb the spare limb into the common bile duct proximal to wherever there was the big damaged bit, and the rest you tie off. So an ERCP, so let's show you a picture. Here it is. So this is the endoscope, which is coming through the mouth around the duodenum. And here you have the pancreatic duct and the common bile duct joining with the sphincter body guarding the ampulla ovata where the bile comes out. And here the scope comes all the way down. You place an instrument into the common bile duct, and you can inject dye. And in this case, you can also fish out this stone with a little net. There are some complications with ERCPs, which are very important to note, because part of your job as a junior doctor will be to go review people once they've had their ERCPs. And the things you'll be looking out for are abdominal pain, bleeding, and after they had lots of sedatives, they might be very nauseous or very kind of dangerously sedated with respirate and things like that. So complications of ERCP: bleeding, about 1%, which rises to 1.5% if a sphincterotomy is performed. Now, sphincterotomy is when you make a small cut in the sphincter of Oddi, which means that any obstruction is less likely to reoccur if there's a stenosis around here, or if there's a reason that things can't get through properly. You can cut the side of the sphincter and let that all drain out much better. You have to use monopolar diathermy for that, and therefore it will bleed slightly more. Another thing you can have is duodenal perforation. You're instrumenting the duodenum, and it can unfortunately sometimes perforate, but it's very low incidence. Cholangitis, because you're instrumenting something foreign into the biliary tree, you can actually introduce infection, and also because you're putting dye up it, you can introduce inflammation into the pancreas, which is a 1.5%, which is is one of the causes of pancreatitis. After alcohol and ethanol, it's one of the most common. So this is the percutaneous transhepatic cholangiogram. Let's say you're doing the ERCP, and unfortunately there's a stricture in the duodenum, or there is a reason that you can't get to this gallstone, which is lodged there. And despite your best efforts, despite your consultant's best efforts, you can't do anything to get it out. What do? Your options are fairly limited at that stage. You're not going to just give it another go with someone else because you trust that that go was proper. There's risks each time you do it, so you don't want to just repeat it. So the thing that they usually do is a percutaneous transhepatic cholangiogram. Essentially, if this is coming from the bottom and going up the tree towards a stone, this is coming from the top and going down the tree towards a stone, and it comes percutaneously and through the skin, through the liver, percutaneous transhepatic, and then into the biliary tree cholangiogram. And then from that side, you can put the dye into the tract. So in this instance, you can see this is a tube which is going through the skin, through the liver. The dye is then injected somewhere around here, and the dye is going all over. It's going down, it's going up the cystic duct into the gallbladder. It's also going down towards where the narrowing is. In this case, it looks like it's probably a stricture. Sorry, I'm just going to grab some water very quickly. And that's why you can see that they do the PTC, and they often stent it at the same time to then allow it to all stay open and patent. So I said we've covered now the main spectrum of biliary disease. So we've covered biliary colic, asymptomatic gallstones, cholecystitis, and cholangitis, talked about the key principles of investigating them and the key principles of managing each of them. Now we're going to cover briefly for the last 10 minutes or so, before we have some questions, some other conditions, and we're going to do it in the form of little cases, so little MCQ questions. Don't worry, these are the harder ones. So if you've not heard of these things, that's fine. The point of them is to get them wrong and learn. This wouldn't necessarily be, what finals are structured like, but maybe exams beyond there might be like this. So question 1, a 43-year-old lady with repeated episodes of abdominal pain is admitted with small bowel obstruction. A laparotomy is performed, and at surgery, a gallstone ileus is identified. What's the most appropriate course of action? So I'll give you 30 seconds to think about that and read the answers. And if you don't know what a gallstone ileus is, great, you're about to learn. So a gallstone ileus is when you have a gallstone in the gallbladder, and in the case of cholangitis, it might travel through the cystic duct into the common bile duct and cause problems there. But in this 43-year-old lady's case, what's happened is that because there's been repeated bouts of cholecystitis and repeated bouts of colic, the gallstone has managed to cause a fistula, so an abnormal connection between two epithelial surfaces, between the gallbladder and the closely related duodenum. Remember the anatomy that we went through at the beginning. So in this case, the gallstone has gone from here straight out through the hole into the duodenum, which meant that the gallstone is no longer in the gallbladder and it's now in the small intestine. That will then travel along, or all the way down, all the way through the small intestine, until it will most likely get lodged in one of the narrowest bits of the small intestine, the ileocecal valve. So at this point, it will cause a bowel obstruction. So you present with bowel obstruction, but the actual cause is a gallstone. And that's why it's called a gallstone ileus. Ileus meaning slowing down of the gut. It should really be called a gallstone bowel obstruction, but it's not. It's called a gallstone ileus. But now you know. So to treat it, you want to remove the gallstone, and you want to do it via approximately sighted enterostomy. So enterostomy, so during the operation, you cut a small hole in the small bowel, 20 centimeters proximal to the gallstone, because if you do it right here, it won't heal very well because all that tissue is very angry and inflamed. So you do it up here. You then fish out the gallstone, suture up the hole that you've made, and you leave the gallbladder be, because it's Just like if you do the operation on day 5, this area is very hostile, and anything you try and achieve then will probably lead to more damage than good. Okay, so we've covered gallstone ileus. So the next kind of sort of uncommon type of thing, which we'll cover. 68-year-old man with type 2 diabetes is admitted to hospital unwell. On examination, he has features of septic shock and also right upper quadrant tenderness. He's not jaundice. Imaging shows a normal caliber bile duct and no stones in the gallbladder. What's the most likely diagnosis? So the question is kind of leading you along the cholecystitis, but then there's a bit of a curveball and saying that there's no stones in the gallbladder, which isn't something that we've talked about yet. So we can probably just by, even if we didn't know what these things all meant, and we'll cover Maritz's syndrome in a minute, but we've covered cholangitis, so we can know it's not that. And is it acute calculus cholecystitis, i.e. with a stone? It's not that, because we can see there are no stones. So just by process of elimination, a bit of exam technique, we can probably deduce that it's acute acalculous cholecystitis. So this is when you have inflammation of the gallbladder in the absence of gallstones. So here's a nice ultrasound of the gallbladder being thick-walled. So usually above 5, certainly around 7 millimeters or above of thickness. And that's measured by the ultrasonographers. This is in exams, you'll see this. If you see type 2 diabetes, no stones, and what you think looks like cholecystitis, it will be acalculous cholecystitis. But it's also more common just when people are generally unwell. So in hospital with something else, very unwell, they might develop acalculous cholecystitis. And this is managed exactly the same way. So there's nothing extra to learn. So you treat it with antibiotics. This is still at risk of infection, and you still treat it with laparoscopic cholecystectomy. So question 3, a 41-year-old lady is admitted with colicky right upper quadrant pain. So similar to our lady from the first case that we did at the beginning of the session. On examination, she has mild pyrexia and clinically jaundiced, again, similar to the one we talked about. An ultrasound scan is reported as showing gallstones, and the patient is taken for theatre for an open cholecystectomy. So far, so normal. At operation, Calors Triangle is almost completely impossible to delineate, and we talked about what Calors Triangle is a little bit earlier. What's the most likely explanation? So if you haven't heard of Maritz's syndrome, good. Now you're going to learn about it. Maritz's syndrome is an exception to the rule that cholecystitis does not present with jaundice. And once we explain why it happens, it will be slightly more obvious about why the jaundice is there. So you have stone impaction. So a stone has traveled from the gallbladder and usually in the cystic duct, and it's causing inflammation of that area. Or sometimes it's just so big. Either way, it's pushing extrinsically onto this common bile duct. So remember, whenever we talk about obstruction, you can have obstruction from within, i.e., having like gallstone ileus would be an intestinal obstruction from something within, or you can have mural cause, or you can have extramural. So in this case, it would be an extramural compression of the common bile duct, which is causing biliary stasis. And it's most common when you have recurrent infections. And the question will often tell you about, difficult surgery or impossible to delineate anatomy. And that's because everything's so inflamed, because it only happens when there's recurrent infection, that it's just very difficult to see what's going on, because everything's inflamed and red and everything looks the same. And sometimes because of that, it's unsafe to do a complete laparoscopic cholecystectomy, ectomy being removal, because you wouldn't be able to appreciate the anatomy. There's a much higher chance of injuring the common bile duct and causing bile leak, or worse, bile duct injury. So you can do an operative cholecystostomy, which is a hole in the gallbladder. So ostomy is when you make a hole in it. and you can just remove the infection. So you can remove the pus in the gallbladder, and that will remove the sepsis and help, at least for the short while, to let things settle down. So the penultimate question, 55-year-old accountant has jaundice and a temperature of 39 degrees. He's known to have gallstones. Blood cultures have shown a gram-negative bacillus. Imaging shows a bile duct measuring 1.2 centimeters in diameter. What's the best treatment option? So this one we have talked about directly in this talk. So we have Charcot's triad there. We have jaundice, we have temperature, and we have right upper quadrant pain. Well, actually, it doesn't say specifically, but there's right upper quadrant pain. So this patient has cholangitis. So we've talked about the different things there. So what is the best treatment option? So already the question is about treatment. So we can get rid of the MRCP and ultrasound, which are investigations, and we can think about ERCP or PTC, which we've explained beforehand. And the right answer is ERCP. So we're instrumenting it. We're fishing out, if we can, the stone in the common bile duct, and we're stenting it to make sure it stays open. A PTC and drain or stent would be if the ERCP fails. The last question is a 33-year-old who is admitted with cholangitis. Her bilirum is 180, so very high, and her Elcps is 348, so very high. She becomes progressively more unwell and develops abdominal pain. You check her amylase, which is elevated at 1080, and the diagnostic threshold for pancreatitis is above 300, so that's very raised as well. Standard treatment is initiated, and her Glasgow score is 3, which is a scoring method for pancreatitis. What's the most appropriate course of action? So in this case, you have someone with cholangitis. And remember, we talked about this a little bit earlier, is to consolidate that, is that the stone can travel further down and cause an obstruction more distal in the biliary tree and actually clog up the pancreatic duct as well. And that's when pancreatitis will occur. So the primary issue at that stage is there's a stone in the biliary tree which needs to be removed. And as we've just talked about, the ERCP is the best way to do that. Brilliant. So that's the coming to the end of the session. I just wanted to kind of, it's difficult to take in any or all of that, but for sessions like this, if you can take away a few things, that would be fantastic. So we talked about the spectrum of gallstone disease. So we can briefly describe asymptomatic gallstones, biliary colic, cholecystitis, and cholangitis. Those are the 4 which would be important to know for the medical take, so surgical take, and on ward rounds and in exams. So that's the spectrum. And we've talked about the different investigations and the management techniques you can use to treat all of them. And then as a bracketed take-home message, you've been introduced to the less common presentation, so the Gallstonitis, the Miritzi syndrome, and things like that. Everything that we talked about in this session will be released on the Mind the Bleep surgical webinars page, so that you can access all this material. The slides themselves will be available on YouTube and through the Mind the Bleep website. But if you just prefer to read it in a PDF or Word to get all the information as quick as you can, then it'll be available for you as well. So I'll just pause now and wait a few seconds because there'll be potentially some questions which we can talk about. And I'll wait for my colleagues to let me know if there's anything like that, and I'll hang around. But otherwise, thank you very much for listening. There's a feedback slide here, and absolutely rely on your feedback. So please, if you can, just get your phone out and scan that. It takes literally a minute to do it. And we really need it as organisers in order to improve for you next week, see what you like, see what works, see what doesn't. It's obviously quite hard to make things interactive, but if you have any ideas, that would be great. And also, we need it for our portfolios, essentially. So that would be absolutely great. Thank you very much. I'll see if there are any questions, and then otherwise, have a fantastic evening. Just managed to log in. I know it's a bit late, but if Surgeon Shifa is listening, a question was asked, what's the best antibiotic for cholangitis? So it will depend. You'll need gram-negative cover because E. coli is a gram-negative bacterium. And so that definitely needs to be covered. But you also need some broad spectrum because at that stage, you don't know specifically that it is E. coli. So each hospital will have their own guidelines. So for mine, for example, the first line for uncomplicated cholecystitis would be comoxiclav, 1.2 grams IV 3 times a day. If you have cholangitis, then you will add often ciprofloxacin or metronidazole to get anaerobic cover as well. But wherever you're working, there'll be an app or a guideline somewhere, and you will just give that because everywhere's a bit different. Right. Thank you very much, everyone. Hope you have a nice evening. Oh, QR code not working. Okay, we'll post a link for the feedback and put it in the chat of the video. Thanks very much, everyone.